I have nothing to disclose related to our discussion today. I'm going to be talking about some core concepts related to harm reduction. I'm hoping to kind of just introduce you to the model of harm reduction. We use that term all the time, but we don't always clearly identify what does that mean to use harm reduction, and kind of where does that come from? What is that in alignment with versus an abstinence only model? Address and I'll go through some sort of exemplar studies that show the benefits of harm reduction, particularly with an opiate use disorder population. And then I'll wrap up by showing you some actual techniques that fall under the harm reduction umbrella that you could apply. And so they don't have to be part of any kind of traditional psychotherapy. Like, you could add them into whatever your treatment as usual, whatever your role is. They're really easy to apply techniques that can help people move in the direction of increasing their safety and wellness as you're working with them. So I like to start this conversation because I think this group, it hasn't come up so much, but in previous groups, helping to just shift the mindset away from drugs are bad, people should just stop using drugs, and help you really connect, I think, with the more human perspective. Why do people use them, and what are we actually asking them to do, right? And so I think one of the best ways to start to connect with that is to do this thought experiment. And just ask yourself, like, as a functional adult working professional, you have stress, you have distress, you have things happen in your life. When that happens, how do you handle it, right? What are some of the things that you may do? And you don't have to answer, but just be thinking in your mind. A lot of us may have close relationships that we seek support from. Maybe we go and hang out with friends or family. Other people, maybe their default is, I might go to the gym, or I might go to a yoga class. Maybe I sit there and binge watch Netflix. I know that's kind of my go-to, a big submarine sandwich. Yeah. So eating, right? And even if you were to say, like, I might have a glass of wine, or I might, I might actually use a substance, but maybe not to excess, but I might do something to just help me manage that stress, right? So just connect with whatever that is for you and what relief that provides you. And then ask yourself, these questions. What if someone told you to just stop doing that thing? How would that make you feel? Or what if somebody actually took it away from you, and that was the one thing that actually helped manage that stress, helped in that moment? Or worse, what if somebody actually punished you? What if it was illegal and they put you in jail for doing it? The one thing that just helped you manage what was difficult in your life. Maybe it was a painful emotion or painful experience, or family or work stress. Or even worse, what if you actually felt like a bad or broken person for engaging in that behavior, for doing that thing that gave you comfort in that moment? And so I ask people to just kind of consider this, because if we're going into that writing reflex, if we're unintentionally jumping on board with sort of the general social approach, which is to see drug use as inherently something bad that should be stopped, and people just need to stop it, that we might unintentionally forget about just how difficult it is for people to stop engaging with something that truly does give them comfort, that they may be bonded to, they may have deeply entrenched in their social or family relationships. And so it's not as simple as just stopping. That we really want to work to understand what this means for the individual, and all the different kind of the web of connections that get formed around substance use. And then when we add in the fact that a lot of the patients we're working with, they're not as functional as those of us in this room, that they may not have as many resources to tap into to navigate the difficulties that they're experiencing. So just some things to keep in mind. And this all ties into where harm reduction comes into play in terms of our modern approach to treating substance use, because we really have viewed it differently over the course of time. And these different treatment perspectives are still with us today. That this history follows and is very much a part of why this continues to be one of the most stigmatized conditions. So going all the way back to the beginning of when we first really started addressing substance use, at least here in America, I'm speaking about the United States of America, I'm not speaking about the whole world, but historically how we've treated people with substance use disorder, we have multiple iterations throughout our history of treating it as a crime. And that is still very true today, that there's a number of things that are either related to behaviors around engagement with substance use, whether that's some involvement with possession, intoxication, and or distribution of substances. There's a heavy criminal repercussion involved in that. And we know that once people end up in the criminal justice system because of their substance use, however that is connected, that has long-term impacts in terms of their prognosis, their ability to kind of course correct, right? So that's very much a part of the lives of the patients we're working with. We also have multiple time periods where we've viewed addiction as a moral problem or failing, and that is still very much with us, right? And we see that in some of the language that's used around that this is a failing of willpower or a weak character. People don't want it bad enough. Where I hear it most show up with learners or with people that I interact with in treating this population is sort of saying, well, they're not ready or they're not motivated, as if that's something that we have to wait for versus something that as providers we can actually help them to get ready. So I think that's still very much with us. We also, in more modern times, have viewed it as a disease, and we can still use that term, but I don't think it quite captures the full picture of what is a substance use disorder or an addiction, that a disease sort of has this cause and effect relationship associated with it, versus what I think is more accurate is to really view it as a complex, multifaceted condition, because it isn't just what happens to their psychology or their physiology. It's also what happens to their social relationships, their environment, and how all of those things are connected. So really understanding that it's greater than the sum of its parts. And so when we're trying to approach treating this population, recognizing that there are so many different layers and connections to why they use, how they use, when they use. And so we really need to understand that full thing and see it as multifaceted as it actually is. So how we think about addiction really does matter, because it informs the treatment approach that we take. So seeing it as a chronic condition similar to asthma, hypertension, diabetes, recognizing that there's a heavy genetic contribution, that even though there are similar weights in terms of personal choice and lifestyle, there's also a lot of contributing variables to why somebody ends up with this and why it gets maintained that is outside of their control, right? It could be the culture in which they develop, what they're exposed to, such as trauma, all of these different things that may contribute to, again, the development and maintenance of substance use disorders, but are not necessarily associated with that kind of personal choice. So we want to pull back this idea that it's about motivation and willpower alone. We also know that medication adherence and relapse rates are very similar, and that if we view it from a chronic care perspective, we want to be educating and also thinking about it ourselves, that patients are going to need to be able to move up and down the continuum of care as needed over the course of that condition, right? So sometimes they're going to need a higher level of care, and other times we're going to have to think about how we step them down from the level that we're providing, because they likely will need some type of maintenance, even if it's community, peer support, family support, whatever that might be, for a long period of time. That it isn't just a short stint or one episode of care in a residential treatment program, but thinking about how they actually make these changes over a long period of time. So that's important, to really thinking about continuous care rather than this kind of cycle of episodic care where we wait until people are pretty acute or pretty severe before we really treat them. So looking at how we can kind of move them up and down that continuum. That we're not looking for a cure for this condition. We expect that we can talk to them about, just like with diabetes or asthma, how can you make improvements? How can you move in the direction of health and wellness, and things that give you meaning in your life, rather than waiting for that abstinence goal to be achieved, or that even abstinence is the ultimate outcome for people, because that may or may not be true. Recognizing that sobriety doesn't equal recovery, right? That when we're talking about recovery, we're talking about people that are as functional as they can be, and are as healthy as they can be at that point in their life, recognizing that there are a lot of other factors, and that we want people to be engaged in things that give them purpose and meaning, regardless of their use level, right? That use is only one of the multiple variables that we're helping them to think about and make improvements on. So that's where harm reduction comes into play. Harm reduction is really a wonderful approach to being able to have these conversations and help people not just reduce their use, and it could be to abstinence levels if that's their goal, but also focus on other things that are correlated with reduction in use, even though we're not directly hitting that, which is how do you make improvements in your health and social functioning? And all of that is going to translate to improvements in public health and safety, which, as we make communities safer, as we work towards trying to decrease the incidences of trauma exposure and community violence and other things that we know go hand in hand with substance use, we can see a bidirectional effect, which is also going to have monetary improvements, or decrease in monetary costs as a society. So where does harm reduction fit in? Typically, in most recovery models, we sort of see it at the beginning of care. So when patients are highly symptomatic or acute, or when they're new to care, harm reduction is really an excellent approach to take. It fits very well with MI or ME approaches. Although anyone who's seen that lecture, we can apply harm reduction with patients who are pre-contemplative. So patients who may not necessarily be at a space where they're open to motivational interviewing, intervention being the ideal approach. Harm reduction can still be used. And then a lot of the other interventions that are recommended kind of fall in that middle section. And then we follow it up with relapse prevention. And so that this kind of gives you a little bit of a timeline for where harm reduction would fit in. So what is harm reduction? Well, it really is a model of care, not a specific intervention. So as long as what you're doing, whatever that specific intervention is in the service of these domains. So it's provided with a focus on respect, accepting who the person is, where they are, collaborating with them on their goals, with next steps, what's important to them, having compassion. So kind of like in the beginning, really understanding that it's not as simple as just quitting, that it's not it's not just about negative consequences and trying to avoid those negative consequences, but that they have legitimate connections and in some ways a bond to this drug. And that provides them significant relief. And so trying to really see that through the lens of compassion, and then always seeking to empower them to make the best choice for them today. That's one of the benefits of harm reduction, is that it isn't something that's down the road. It's something that happens right now. What can you do today, even if it's the smallest shift or the smallest change? Harm reduction has been around for a long time. It actually comes from public health perspective. It isn't from the realms of psychiatry or psychology, although it's been adopted and used for a number of things. But we use harm reduction all the time, right? Such as other preventative measures, sunscreen, seat belts, bike helmets. Medication-assisted treatments would fall under the harm reduction umbrella, right? Because we are trying to help people shift into using this instead of that, into making more informed choices and to getting themselves unstuck from that cycle of withdrawal and intoxication. Other examples of harm reduction are things like clean needle exchanges. And even though we don't have any here in New Mexico, there's some good evidence that supports things like safe healthcare run injection sites are also effective harm reduction strategies. So providing spaces for people who are going to use, but who can do that safely and they're not at risk for becoming victims of crime or violence or overdose. And then additional things like mitigating and trying to decrease sexually transmitted diseases or other infectious diseases. So having HIV, Hep C testing, providing prophylactic medications or condom distribution, sex education, all of these things fall under that umbrella and are good components to include in a harm reduction model of care, in addition to discussions about decreasing use. So with harm reduction, our major goal is to just reduce the harmful consequences associated with their high-risk behaviors. Substance use would be included in that, but it could be a number of other things. So we could apply that to what is unique to that individual in terms of their high-risk behavior. We also want to shift their focus from I have to wait to do this to you can do it right now. What can you do today that would be in the service of helping you be as functional as you can be, right? What would be in the service of helping you to make some form of improvement. And it's done with that mindset of collaboration and compassion. So you're not trying to force a specific standard or judgment on people. And in fact, there's a lot of research that supports when we use judgmental, confrontational approaches, which some programs that fall under an abstinence-only approach can do, such as discharging people from treatment because of a lapse in use or a positive UA, that unfortunately that results in the individual feeling as if they failed and walking away from that experience not getting the adequate dose that they need to improve their life and their safety and well-being. So that actually ends up in a pretty negative outcome. So we really want to be thinking about what can we do to help people just be safe and functional. So I'm going to go through a couple studies and just show you what I think is pretty stark evidence in support of harm reduction models. So this is one I think you guys have seen repeatedly, looking at buprenorphine versus detox. And you can see there's quite a stark comparison between the cohort that was placed on buprenorphine maintenance care, how they had 0 deaths, how they were maintained in treatment, so treatment retention over 350 days versus the population that was placed on detox, a pretty precipitous drop in terms of retention and care. And then for deaths. So right there is just a pretty big comparison when we treat people from a harm reduction perspective versus an abstinence perspective. This is another one that looks at not use behavior or death rates, but criminality. And so there's a lot of stigma around methadone clinics or where methadone treatment is provided, in this idea that there's going to be increased criminality in those areas. But the evidence is actually the opposite of that. So we see where people are engaging in criminal behaviors to support ongoing use because they're in that cycle of withdrawal and intoxication. When we provide them an alternative, such as methadone, we see a huge change in their engagement in those same criminal behaviors. So blue is the patients that were engaged in criminal behaviors before methadone treatment, and then yellow would be during treatment. So pretty significant a stark contrast there as well. And then this one is one of the more controversial studies that was actually done in Switzerland. in the 90s to early 2000s, where they said there's a population of patients that are not going to be successful with either buprenorphine or methadone, but we know that they're at high risk for death, and at this time, HIV/AIDS infection. So what they decided to do, and I think that according to the study, it was sometime in like 1994 where they decided to prescribe pharmaceutical grade heroin to these patients and provide them clean needles in order to use. So they changed nothing about the rest of their care, except they switched from street available heroin to pharmaceutical heroin, so prescription for that same amount. And they saw a pretty significant change both in overdose deaths as well as deaths associated with HIV/AIDS. So right there is just again, an example of, even if we make the smallest change to help them be as safe as possible, we've changed nothing about their use or their amount of use, we can still have a positive impact. So from this philosophy, we really go in with the assumption that individuals who use substances are experts in their life, and we want to capitalize on that they have strengths that they can use in the service of making those positive changes, that we as healthcare providers can align with those strengths and use them at any point during their care, that substance use is complicated, exists in complex people and in complex social situations, and it isn't as straightforward as just stop doing that. That we can actually categorize use across a spectrum of harmful to less harmful consequences. And so we don't want to see it as all good or bad, black or white. Okay, so that's the model pieces. And I'm just going to spend a few minutes and introduce you to some techniques or some skills that you can use that are in the service of harm reduction. Now, this is called a decisional balance, and this can be used for people. I would not use this for folks that are not in a pre-contemplation place, right? If they're already kind of, I'm ready to make some changes, you wouldn't use this technique because it could have them start reevaluating the pros of using. So we don't necessarily want to use it with everybody, but for people that are brand new to treatment, people that are still pre-contemplative, and we want to take a harm reduction approach, this can be a really effective, simple technique. And it's just a fancy pros and cons list. So you can draw this on a piece of paper, you can print out something that you have readily available, but it's just on one column we have continuing to the behavior. It doesn't even have to be use, it could be any other high-risk behavior. And then in the other column we have changing the behavior. And then we have those crossed by the pros and cons of each. And then you go through and you have a conversation and have the patients list for you what are the pros of continuing, what are the cons of continuing, what are the pros of changing, what are the cons of changing. So this is an example where you can see that listed out. The next step that's important is that you put a numerical rating with each one of these items. So once you've got the items and you ask them to rate on a scale of 1 to 10, how much of a benefit would this be for you? How much of a cost would this be for you? So that you have some kind of a numerical value to compare it to, because the final step is to create a hierarchy of needs. So then you can rate based on what you have here. You start with your 10s and then you go down, and you put it in what is most to least important. So you can see for this individual who came in with an issue with methamphetamine, stopping methamphetamine is not on the list. What is number one? Managing their chronic pain, right? So then that right there gives you an in that's meaningful to them, that you can start to work from a harm reduction perspective. If I help them to better manage their pain, I connect them with services to help them manage their pain. That may have some downstream effects to actually changing their use behavior or engagement in other high-risk behaviors that are connected to that. Another approach is called a functional analysis. And this is a similar way of kind of helping people really think through the positive consequences, the negative consequences, and all of the variables that are connected to that use behavior. So this is just an example. There are multiple ones out there that you can use, but this is a great way to start the conversation to get an idea of what triggers them to use, what are the thoughts and feelings that are connected to it, what are the behaviors that they engage in, and then what are the downstream effects. So this is one example using that same that you could look through and kind of have a comparison and see where, at which point they can intervene, where they can start to make a change that's in the service of doing something positive. Another way is to help people start to track their cravings or their urges and to rate those intensities, because then that can help in the conversation of saying, how can you start to avoid some of those situations or engage with those situations differently. And then the last technique is called high risk situation planning. And if you do none of the above, this is one of the number one things that I recommend that everybody working with the substance use disorder population adopt. You can do this in the last 5 minutes of every single encounter. This one's already pre-filled out. You can just do a blank sheet. It doesn't have to be something pre-filled out, but it's something that they can keep with them in between sessions. What is coming up for you that is potentially high risk, where you're at risk to use, and what's your plan for dealing with that? So it gives them some additional things to flush out so that they're more likely to be successful in either avoiding or managing that high risk situation than to have zero planning or preparation around it at all. Okay, so I think that's it for the lecture. Were there any questions?